Hello, I'm Dr. Greenbrier Almond, the son of Harold David Almond, MD, who wrote the Stories of a West Virginia Doctor, which we are reading today. We are now ready to begin part 3 of the Stories of a West Virginia Doctor. The Diagnostician. A nursing student's headaches. She was our last office patient that December night in 1983. It was cold, wet, rainy, and was near Christmas. My nurse commented that if a person was out on a night like this, then she must be sick. This young woman had been referred to this old doctor by her mother-in-law. She looked sick, almost desperate like she needed a stronger pain medication. "If you can't help me, then I don't want to live. My headache is ready to blow the top off my head." She relayed this complaint with so much sincerity that I looked to see if the skull of her brown hair was coming loose. She was young, only 22, and was a hospital aide who was currently enrolled in a 12-month course to advance herself to a licensed practical nurse, an LPN. The history of her headaches started 15 to 18 months before as a mild nuisance in the head and was easily controlled by an occasional aspirin. The nuisance became a misery, and the misery became intense pain. Now the pain was blowing her head off. 18 months ago, the nuisance occurred once or twice a month, and now the pain came almost daily. About 12 months ago, she had also started her LPN course. She loved it, and many things she had learned as a hospital aide helped her to get good grades. She had to study a lot. There was so much to learn and to memorize and to remember. She gave up her aide position. Then her husband lost his job. Next, the power company cut off the electric to their trailer. And now she and her husband and 2 young boys had moved in with her mother-in-law. Everything was going from bad to worse. She didn't feel like cooking, cleaning, or even playing with her 2 young sons. She would lie on the couch after supper watching her family, but lately she realized that this was the time when she got her headaches. After hearing her history, I began to think of all of the possibilities. She had already had her glasses checked. They were functioning very well. In migraine headaches, the patient usually smells or sees something odd about 15 minutes or so before the headache. Also, with severe headache, the victim, like Lewis Carroll of Alice in Wonderland fame, usually sees some bizarre figure during the attack. He wrote in that wonderful book that Alice at times was so small that she couldn't see through the keyhole. Once she was so small that she couldn't open her mouth because her jaw was on the floor. None of these characters were ever visualized in my young nurse patient with her severe headaches. She had twice been to an excellent clinic in a nearby town. She had seen 2 third-year medical student residents in the emergency room. She had seen one of our younger local doctors. She had been told by everyone that she had tension headaches. The Lord knew, and I knew, that her schooling was tough. Final exams were 10 days off. Money was non-existent for her family. Living with her family of 4 in the same trailer as her mother-in-law was ample cause for severe headaches. Brain tumors cause headaches only in moderate to advanced states. My examination of her pupils, then her right eye ground and optic nerve with the ophthalmoscope showed no internal pressure within the skull. She was not dizzy when standing with her eyes closed. She could read fine print and could hear the watch tick. Her blood pressure and pulse were both normal. She was well aware of the time, place, and person. She was smart. She would make a good LPN. Her heart, lungs, abdomen, and limbs were all normal. She had good muscular coordination. But then the night was cold and rainy, and her mother-in-law had sent her to see the old doctor. Doctors and nurses sometimes need a coffee break. It is time to think and remember. As I was drinking my coffee, I thought back through my years of experiences. In August 1945, in the 580-bed Chicago hospital where I was an intern, I saw a 32-year-old call girl with similar headaches to the ones described tonight. I recalled her saying that sometimes when she was at work, these severe headaches would occur suddenly. I remember the attending physician and I palpating deep down in her abdomen in the area of the kidneys. And one time we precipitated one of the devastating attacks of pain. Her pulse started to race from 72 to 120, and her blood pressure, which had been high normal rate, now was astronomically high. I asked the young nursing students if she had ever awakened at night with her heart pounding. She promptly started and stated, "Yes," and then I immediately get my headache. Finally, I could make a diagnosis of this nursing student, the same as the doctors had made in 1945. Both patients had tumors of the adrenal gland. Both tumors released adrenaline into the bloodstream and immediately increased the heart rate and contracted the arteries and caused hypertension. It was as if they had received a shot of adrenaline. The adrenal glands are on top of the kidneys and secrete cortisone and adrenaline. The young nursing student was hospitalized for 2 days. A 24-hour urine specimen was positive for adrenaline-like compounds. Also, her blood pressure during 3 attacks was taken and compared with the basal pressure. All 3 readings were well over 200 over 130, with her normal being 138 over 86. The CAT scan was taken of her right adrenal, and sure enough, the tumor was found there, just as her history had revealed. As she lay on her right side on the couch while she watched her young sons play on the trailer floor, the headache occurred. We scheduled our patient for surgery right away to remove her tumor. The surgery is tricky because the tumor is about 1/2 inch by 1/2 inch by 3/4 of an inch. And while the surgeon isolates and ties off blood vessels, the blood pressure goes up and up and up. The anesthesiologist must now and then give a strong medication to lower the blood pressure. When the tumor is removed, the blood pressure falls rapidly to a very low level. Now the patient needs medication to elevate the blood pressure. The surgery was successful. The patient passed her state LPN boards and soon enrolled in an RN course. Coffee breaks are an institution among coffee-drinking doctors and nurses. So naturally, one morning when the mailman delivered the surgeon's report about this patient, I pondered his unusual inquiry over a cup of coffee. Since it was only the surgeon's second operation for a pheochromocytoma, he wondered whether I had another case, as I knew these are found in only 1 out of every 400,000 patients. Luckily for my nursing student, that dreary night, I had beaten the odds by having seen 2 cases in my practice. The starving baby. The call was 30 miles upstream to see a newborn baby whom I had delivered 6 weeks ago. The summer was 1955, and the baby was vomiting excessively. The family lived in the rural mountains of West Virginia, and the depression was still there for the uneducated and the unskilled. There was government commodities and a small welfare check, also free running water from a Sweetwater spring. There was an outhouse, plus bass and trout in the Buchanan River. The garden was on a hillside, well worked, but the yield was so-so. The road was rock-based almost to the house, but I had to walk up the trail the last 100 yards. The heat was coal wood range, felt good that rainy afternoon, and the smell of old-fashioned blackberry jam in the making added temporarily to my spirits until I saw how sick the baby was. The baby was a girl and had weighed 7 pounds at birth. She had been healthy when she was born, and her young mother, who loved her dearly, was breastfeeding her and trying to give her good care. Despite the loving care, the sick baby was off its 7 pounds and down perhaps to about 5.5 pounds. The vomiting was projectile, and there were visible waves of movement in the stomach. I made a quick but educated diagnosis. I believed the baby had pyloric stenosis. This was an unusual, almost unheard of condition in my practice. The valve at the outlet of the stomach was congenitally thickened and wouldn't grow as the baby developed. The thickened circular muscle around this baby's pyloric valve was the cause of the vomiting. The baby was doomed unless operated upon immediately to relieve this obstruction. My single experience was one case that I had seen in April 1949. An Air Force officer's son had a similar episode of vomiting, and I flew with him to a larger military hospital in southern Japan. The diagnosis was the same, a pyloric obstruction. The Air Force surgeon had invited me to assist in the operation. Here I had seen my first Ramstead operation to cut these circular muscles. Drip ether was used, about 5 to 6 drops per minute. The starved little boy in 1949 had barely awakened from surgery when he received formula. He was so starved he hung on to that nipple, and he took deep gulps of formula, one after another. There was no further vomiting. His constipation was gone, and he gained 2 ounces a day after surgery. Now, today, the sickness was the same, but money in his West Virginia home was nearly non-existent. The mountain mother and the sick little baby rode back in my Jeep to St. Joseph's Hospital in Buchanan. I consulted with the 2 other general practitioners and our board-certified surgeon at St. Joseph's. None of the doctors had ever treated a baby with pyloric stenosis. We got out the surgery books and studied and studied. We really wanted to refer the baby to Richmond Medical School Hospital or the Cleveland Clinic, but the family didn't have enough money to get out of town. Dr. Page, our board-certified surgeon, restudied the procedure and expressed his doubts. So I asked him if he would assist me. It was great to be young and be willing to take chances. Thank God, however, my eagerness to do the operation myself changed Dr. Page's mind. He said that he would do the surgery if I would help him tomorrow. The baby was down to 5 pounds. The next morning, Dr. Jake Huffman, our anesthesiologist for that day, dripped 6 drops of ether per minute. I noticed he wasn't singing his patient to sleep this morning. In fact, he was all business. Dr. Page didn't whistle the one song he had memorized years ago. His mouth was too dry. The incision was 1 inch long over the outlet of the stomach, and it was down through the right rectus muscles and through the peritoneum. The pylorus was brought up by Dr. Page's ever-seeing right index finger and was brought up into the field where all 3 of us and our 2 nurses took a good look. The circular muscles were cut and their elastic fibers retracted. The operation should have been over, but Dr. Page teased down to the mucosa lining of the pylorus, and a little hole appeared. No matter, the surgeon had done the same thing in 1949, and 1 stitch repaired the hole in the boy in Japan. 1 stitch repaired the hole in Central West Virginia that summer day in 1955. The peritoneum and the rectus muscle of the abdominal wall were sutured, and the skin sutured was next. Now Dr. Huffman was singing another barber's song, shop song, and Dr. Page was whistling his one and only tune. When surgery is going well, everyone in the OR is relaxed. Dr. Page dropped in the nursery after his next tonsillectomy operation to see the baby. Sister Heriberta and I were feeding the little girl. She was starved, and she was gurgling her tune. It sounded to me even better than those sung by my dear operating colleagues. "What are you two doing? You can't feed a baby so soon. She has not yet awakened." "Please, Dr. Page, you go back to your surgery and leave the feeding to us." He went away whistling. All was well. We at St. Joseph's did 9 or 10 identical cases in the next 10 years. After Dr. Page retired, he said this was the most gratifying type of surgery he ever did, for he saw the results instantly. He loved babies, no matter that he never got paid for over half of the pyloric stenosis operations he did. A child with a trigger thumb. It was the day after Thanksgiving and in the middle of deer hunting season. The patient had a trigger thumb. Not his trigger finger, to be sure. He had awakened that morning and there was a thumb that was bent and could not be straightened. He was not in any pain. He was only 2 years old. My knowledge of any trigger finger was limited to the one case of a Railroad Express employee at the 12th Street station in Chicago in 1946. He had traumatized his hand on the edge of boxes and caused a bruise of the tendon sheath of the right index finger. That Railroad Express worker in 1946 had a swollen sheath cut, and the blood and fluid were drained off. But I had never heard of a trigger finger on a small child. I examined 18 books at St. Joseph's Hospital, and in the 19th I found that a trigger thumb on a baby is a congenital defect. The sheath doesn't grow, although the baby and the tendon grow. It is like putting a ring on a baby's finger. And the baby and his finger grow, but not the ring. The ring needs to be cut. The little lad returned to his home in North Carolina, where at Duke University the surgeon made 2 1/4-inch incisions over the sheath at the junction of the metacarpal bone of the hand where it meets the proximal bone in the thumb. Will the 2.5-year-old lad return to hunt in West Virginia? Yes, indeed. Some say he was just warming up his trigger finger. Heart murmur via the telephone. Dr. Basil Page, Buchanan surgeon, was on the phone that late summer evening. His voice was troubled and urgent. Listen to this heart murmur over the telephone. The murmur that I heard at my home that August night in 1954 was loud and crunchy. It was peculiar, to say the least. In fact, I had never heard a murmur without a stethoscope up to that minute. On some patients, I even had to turn them on their left side, and then I would strain to hear the auscultations. My curiosity was aroused, so I grabbed my doctor's bag and my own stethoscope and headed for the patient's apartment. When I entered the home, Dr. Page said he had cured the murmur. Indeed, the 22-year-old male had a normal-sounding heart. I thought Dr. Page was up to his usual pranks. But then the man's wife was crying. Dr. Page had the man sit forward in his chair, and that very loud, crunchy murmur returned and could be heard across the room. Dr. Jake Huffman arrived, and there was a repeat performance. We couldn't even guess or give it a name. Today, we would grade this as a grade 6 murmur. That is, one that can be heard without a stethoscope, as opposed to a grade 1, which can barely be heard with a good stethoscope in a noiseless environment. Dr. Page could make the murmur come by positioning the patient so that his heart would touch his rib on the midline, and the murmur would disappear with the patient on his back. or sitting down in a chair, or lying on his left side. It was asystolic in nature. That is, it occurred with the first of the two heart sounds. The lad did not feel sick, nor was he in pain. The loud murmur had suddenly, spontaneously occurred about half an hour before, and he called Dr. Page immediately. Chest X-ray and EKG were normal. None of us yet knew the diagnosis. Shortly after leaving the patient's home, I went to the hospital to help deliver a baby. During the night, as I was waiting for the baby to arrive, I searched the medical books. At 4:30 a.m., I found in an old Dr. Paul S. White cardiology book a footnote that the air bubble in the mediastinum, or a bubble in the space between the lungs, could cause this murmur. The murmur was caused by the heart beating against this bubble of air in a space between the ribs. This is Hammond's murmur or sign. For years I made it a point to ask cardiac specialists about this murmur, and few had ever heard of it. In fact, most are not aware of its existence. The patient recovered when the air bubble was absorbed. He had previously passed a Navy physical for admission to officer school, but was rejected on that final exam. 3 things doctors and detectives must know. It was a quiet, late summer night in the emergency room. Just then, a 56-year-old chronic alcoholic entered through the door. He was not drinking now. He was just short of breath. In fact, he was hyperventilating about 36 times a minute. He was breathing deeply. His mouth was dry, and he needed a swig of water before he could talk. His story was that for the past 3 weeks, he was short of breath, and it was getting worse. No, he had not drunk any alcohol for 3 weeks. No, he didn't feel sick at all. He just wasn't breathing right. I tried to figure out why his breathing was so fast. People breathe rapidly when frightened to death, but only for a short period of time. Underwater swimmers who have no oxygen mask purposely hyperventilate so that when they dive down beneath the water, it is effortless not to breathe. Early in World War II, our pilots pursued the Japanese Zero fighter planes above 30,000 feet. But above 30,000 feet, even with the mask intact, they couldn't get enough oxygen, and they started to hyperventilate. They reported to the flight surgeons that soon they were drooling at their mouth. Their thumbs and toes were cramping. Their vision was getting blurred. In addition, they lost control of their sphincters, and it started to get cold up there in the blue yonder. Pre-med and chemistry majors in freshman chemistry all recall a simple experiment. The student blows his expired air into a glass tube into lime water. The clear lime water soon turns cloudy. Exhaled air contains carbon dioxide and water vapor. Start your car on a cold day and you realize how much water vapor you exhale. Combine water with carbon dioxide and carbonic acid is made. When a pilot, a frightened person, or in this case, a chronic alcoholic patient, blows out an excessive amount of carbonic acid, then his blood is less acid, or as the doctors say, he has a relative alkalosis. In fact, he must be in a strong acidotic condition. His body must be making an excess of acid. Starvation and diabetes are common causes of acidosis, but my patient was well fed. The test for sugar in the urine was negative. He was taking no medicines. The key to a correct diagnosis was discovered by a microscopic examination of the patient's urine. Urine showed abnormal cells from the kidneys and his tubules. This signified that the kidneys were diseased. The kidney function test revealed kidney failure and uremia. The uremia was serious and the patient expired within 3 weeks. His alcoholism was a bad habit, but was only a red herring in this case. The old adage, 3 things are necessary to be a good doctor or a good detective. Number 1, acquire vast sums of knowledge. Number 2, have keen powers of observation. And number 3, arrive at some logical conclusion. In this case, the diagnosis was made in the emergency room with a urine test and 1 blood test for uremia. The doctor possessed the knowledge to ignore unrelated symptoms and draw a logical conclusion. A family with headaches. It was a Friday night, and the nurse and I were with our last patient when the phone rang. It was a 30-year-old mother asking for a prescription for her 4-year-old daughter. The little girl had an infected throat and had used aspirin, but the aching and hurting persisted. We invited the mother to bring the sick girl to the office. She balked at that idea, and I balked at filling a prescription for someone I hardly knew at all. The mother finally relented and soon brought her child in for an examination. The little girl did have a mild pharyngitis and a little fever, but I could see no reason for the aching and the headache. She also had vomited several times. I was puzzled. As the mother and daughter were leaving the examining room, I noticed the mother was unsteady on her feet. She too had a headache and was dizzy, and she had vomited. The mother also said her 7-year-old girl in the waiting room had been dizzy, and she had missed no time from school. I asked about her husband, but he had not felt sick. He was working a 12-hour shift at an outdoor job. The other daughter, age 11, had been well except for the last 3 nights when she complained of nausea and headaches. With all of this information about the family, I suspected carbon monoxide gas poisoning, probably from a space heater. But I discovered they had a gas furnace. We examined the mother and 7-year-old girl. We arrived at the same diagnosis, carbon monoxide poisoning. I insisted that both of us, the mother and our office, would call the gas company in the morning. She also agreed that she would leave a window open in each bedroom that night. On Saturday morning, my nurse called the gas company. They told her that they were already checking out the home. On Monday, the mother called and told me that I had caused the 7-year-old girl to catch cold from the open windows. I was amused when I considered my possible life-saving recommendations, but I readily agreed to supply medication free for her doctor-induced cold. Of course, I asked the question. I was extremely curious if my diagnosis had been correct. The gas company found that the concrete top of the chimney had fallen in the flue as a result of ice and snow. Workmen removed the concrete pieces, and the headaches and dizziness were over. I felt good that my diagnosis had helped this family divert a disaster. Cotton is the cure. One day in 1975, when I was covering the hospital emergency calls in my office, a young man was sent in by the hospital to see me. He was about 30 years old and had a severe earache. "Doc," he said, "I have been in 2 or 3 doctors and they treated me for an earache, and I just don't get any better. Can you help me?" I examined his ear and found both ears filled with wax, with some discharge, and that was foul smelling. I began to remove the wax, and after some considerable effort and time and some discomfort to the patient, I found some cotton in one ear. I said to the patient, "How long have you had this cotton in your ear?" After an appropriate pause, "Well, Doc, 7 years ago. I went to the Cleveland Clinic and had surgery on my ear, and I never went back for a checkup." After spending half an hour that day cleaning his ears, I sent him home with instructions to use 2 drops of mineral oil in each ear and return in a week. Again, when he came back in a week, I spent half an hour cleaning wax out of his ears. Still, having not completed the job, I sent him home again to continue using mineral oil with 2 drops in each ear twice a day. When he returned the third time, I was able to complete the cleaning out of both ears and see that the tympanic membranes in the ear canals basically were normal. However, in my effort to clean his ears, there was some scratching in the canals and a tiny bit of swelling, so I asked him to return one more time. A month later, he came back and the ears were clearing. The tympanic membrane and canals were clear, and he appeared to be quite comfortable. When I asked him how he was doing, he said, "Doc, I can't stand the noise." To this day, I have never heard from that patient again. The arthritic trigger finger. She was 56 years old and a guard in the Goodyear Aerospace Factory in Akron, Ohio. She had come home to visit her mother in Central West Virginia. She was worried, so her mother sent her to her old doctor. Her worry came from fearing that she would not be able to qualify for her upcoming guard test because of an arthritic condition, arthritis in her trigger finger. Arthritis had nearly crippled her hands, and modern medicines were good, but the trigger finger was not happy. It would hardly perform. She had taken the Akron specialist test, but it upset her stomach. Or taken the Akron specialist medication, but it had upset her stomach. I knew of a practical and usual successful method to treat arthritis. Arthritis of the hand is best treated with melted paraffin. The paraffin on top of homemade jellies and jams. The paraffin is heated in a double boiler to prevent fires. A chunk of hard paraffin is dropped into the melted paraffin to test the temperature. If it melts, the paraffin is too hot. If it doesn't melt, it is about right temperature for the hands. Heat therapy is an old remedy for arthritis, especially when the affected part can be placed on the same reheated paraffin baths again and again. After 3 weeks of paraffin therapy at her mother's house, the guard returned to her Akron specialist for her test. She squeezed the bulb and the mercury shot to the top. Some even ended on the floor. The Ohio specialist was much pleased. "See, that medication worked well," he told the factory guard. Her answer, "The treatment of that old West Virginia doctor saved my job, and it was cheap too." Today, in that specialist's office, an electrically controlled paraffin bath is part of his treatment. X-ray diagnosis. The patient was ambulatory and had probable renal disease. Enemas and laxatives were administered, and the scout film of the abdomen from the first ribs to the hips had been taken. This scout film was done to be sure that there was no air over the kidneys or over the collecting tubules. Then and only then could I give the intravenous dye for the final diagnostic X-ray. The X-ray specialist, Dr. Herman Schultz from Elkins, picked up the film and instantly gave this diagnosis. "She is a middle-aged, she has no teeth, and is a small game hunting season again. Oh yes, she is cleaned out adequately. Go ahead and inject the dye." The scout film had included only the first ribs downward to the hip bones. How do you know? How did you arrive at that instant diagnosis? Easy, dear doctor, easy. The 2 breast shadows indicate her sex. Lessening of calcium in her vertebral backbones showed osteoporosis and thus middle age. And the multiple buckshots in her gastrointestinal tract means she had no teeth. Nobody can eat rabbit or squirrel which has shot in its flesh unless they are toothless. And they only just swallow the game. Yes, it's hunting season in West Virginia. Dr. Schultz was right with this instant diagnosis, and the patient was a woman. She was middle-aged, and she had no teeth. Good detective doctoring. I hand-carried the X-ray film of my 51-year-old patient to the X-ray reading room in the hospital where Dr. Robert Cunanan was at work interpreting the films. I was worried about this patient. I was puzzled as to the correct diagnosis. She had been my first patient after Thanksgiving, and I had examined her in the hospital emergency room. She said her eyes were bulging and she couldn't see clearly. She also, for the last 7 days, she couldn't breathe well, and that her face and neck were swollen. The first look showed the protruding eyes, the cyanosis of the skin of her face, neck, and arms, and even her fingernails, and her breathing was somewhat labored. Now, that was a paradoxical thing during this flu season. All the other patients had to stop coughing in order to get a breath. Further examination revealed a normal-sized heart and normal heart sounds, the usual pulse of 72, and no congestion in her lungs. Blood pressure was normal in both arms. There was none of the cyanosis, or blue skin, of her trunk, nor the lower feet, and there was no swelling in her feet or ankles. Over cups of coffee, 2 hospital nurses and I discussed this case. We reasoned that the venous return from the head, shoulders, and upper extremities was partially blocked, but the venous return from the trunk and lower extremities was good. I was worried and anxious to know the diagnosis, so I scarcely noticed the hospital X-ray technician take the pictures and then process it. Dr. Cunanan placed the films in the viewing box and about a minute later said, "Your middle-aged lady must have bulging eyes, swelling of her face and neck and shoulders and fingertips. Also, she must have labored breathing, and probably when she coughs, she breathes better." He had never seen the patient, and thus I was ready to call Dr. Sherlock Holmes Cunanan. I'd spent 40 minutes in a history taking physical examination, followed by a reasoning session over a cup of coffee. I asked him how he could be making such an accurate diagnosis so quickly. He answered, "Look here, doctor, there is a small tumor in the right upper outer lung field. It probably has spread to the mid portion of that lung. That caused swelling of the lymph nodes, and that in form is causing an obstruction of the superior vena cava syndrome." I asked Dr. Cunanan if this superior vena cava syndrome was common. I was speechless when he told me that in all his years as a specialist, he had looked for this syndrome, but this was the first case. He also told his staff and me that there are only 2 X-ray findings that are acute emergencies, and this was one of them. The patient was admitted to a neighboring hospital immediately where X-ray therapy and chemical therapy could be started that day in order to shrink the obstructing mass that was blocking the superior vena cava. The rest of the day I bragged about the excellent care that the X-ray specialist in our West Virginia hospital gave to my patient and, of course, to all patients. Getting an eraser out of the nose. The 10-year-old girl had lost a rubber eraser of her pencil up her right nostril. Her mother tried to get it out with a small pair of tweezers, but it only succeeded in pushing the rubber tip further up her daughter's nose. The little girl wanted to see her doctor, so her mother and child arrived at the office. The rubber tip was far up the right nostril. I told the mother we could try a simple method to get it out. She blocked off her daughter's left nostril, and blew as hard as she could into her girl's mouth. Out popped the rubber tip, much to the surprise of the little girl. The girl looked at me and said with a smile, "Now, you are not going to charge me, are you?" My mother did all the work. "No," I said with amusement. "You owe your mother. Come back when I can help you." When the blast of air goes through the patient's mouth with a sudden burst, the patient automatically closes her glottis and pharynx, and the blast of air comes out the other nostril. This method can only be tried once, as children do not want to be experimented on but one time. There is no pain and no mess, and it is all over in a second. After I helped my little patient get the eraser out of her nose, I started thinking about just what a wonderful little machine our noses are. The best furnace in Upshur County during this past winter of 0-degree weather was your nose. This unit worked well. It took in 0-degree air, moved it through your nasal tissue, and converted it instantly to 98.6 degrees. God did this for you 18 times per minute. In addition, the humidity of the air was changed to 80%, and impurities were removed. You also could smell Christmas odors at all degrees of temperature. God also uses the same nasal tissue in summer when the temperature is over 100 degrees. Hot air runs through the nose air conditioning to be reduced to 98.6 degrees. The beauty of this useful machine is that it costs nothing for us to operate if we take good care of it. He couldn't see the squirrels. The 74-year-old hunter from Webster County came to our office on Friday the 13th. His chief complaint was that he no longer could see the squirrels. He and his wife loved squirrel gravy. He had a few other complaints like shortness of breath from early heart failure and some crippling arthritis in his shoulders, but the reason he had come 36 miles to the office was his failing eyesight. He was an outdoorsman and had worked in the woods most of his life. Inspection showed a mucous membrane growth partially covering over his pupils, which was causing it to cloud his vision. Doctors and nurses call this pterygium. A pterygium is a growth that is Mother Nature's way of putting on sunglasses. This growth prevents strong sunlight from blocking out the visual portion of the eye. All pterygium that I have seen since 1945 have been single and all grew from the nasal side of the face. My mountaineer patient had bilateral pterygia, and the growth was from the opposite sides or outer sides. I seldom can guarantee a cure with certainty, but I sent my patient to our Buckhannon ophthalmologist, Dr. Jerry Black, who would instill a few drops of local anesthesia in his eyes and then remove this growth. My patient promised that after the growth was removed, he would give me a squirrel tail for my grandson. The February 1989 issue of the Journal of American Medical Association tells of an American doctor's encounter with a 29-year-old Native woman in Saigon, Vietnam. She was the chief hostess in a bar, and she had developed bilateral pterygiae. Her skin was brown, and her pterygiae were brown, dirty brown, she thought. Her eyes hurt and were red. She mistakenly thought it was the smoke and the whiskey that caused the growth in her eyes. She gave up smoking and drinking, but to no avail. She thought her good looks were disappearing, which meant that she would lose her job and be out on the street. The American doctor assured her that he could help her. He wrote down the name of a Saigon ophthalmologist who would operate on her eyes. The woman seemed relieved about her eyes, but she was still troubled. The doctor and patient eyeballed one another again. He asked her what she saw. He asked her what she saw, and she murmured something foreign in his ear. She then asked what the doctor saw in her eyes. His reply cured her depression and her acute anxiety. "I see a beautiful woman with no pterygia at all." She smiled, bowed low, and silently left his office. He never saw her again. This completes section part 3 of the stories of a West Virginia doctor by Harold David Almond, MD.